Okay, this is the fifth and final part of this talk. We're going to talk about some principles for safe prescribing in older adults, which, to put another way, is how to avoid polypharmacy. Well, the first goal is to minimize the number of drugs. One way of doing that is to emphasize lifestyle modification. So in situations where lifestyle modification will have the same therapeutic effect as a medication, we should choose the lifestyle modification, which is harder to do, it's harder work for the patient, it's harder work for us, but in the long run it's better for the patient if they can do it. Maximize the dose of one agent for a specific disease before adding another one. This is recommended in certain situations. It was always recommended for blood pressure, although in the latest JNC7 guidelines they no longer recommend this. They recommend instead that you use multiple medications for blood pressure. But it's a strategy to consider in some situations. It should be done with care, though. The word maximize should not be taken to mean maximum dose allowable in the book. What it should maximize should mean maximum dose tolerated by the patient. So in order to know that, we need to frequently monitor the patient for side effects. We need to ask specific questions, especially if we're thinking about those occult side effects like incontinence or ED, as we saw in that case. The patient typically won't tell you about those unless you ask specifically. Next principle, use one agent to treat two conditions. This is typically done for patients with hypertension and BPH. We can use tirazosin, which is an alpha blocker, which can achieve both of those things. Stop medications that are no longer indicated. This should be obvious, but commonly is not done. We just have a tendency to keep continuing medications without really stopping to think about it. Minimize the use of anticholinergic agents and discontinue when possible. Anticholinergic drugs are a big deal because, especially for the elderly, they tend to cause a lot of side effects. Dry mouth, constipation, urinary retention, blurry vision, and possibly the most important one is confusion or altered mental status or delirium. And there are lots of anticholinergic drugs out there, and a lot of drugs that we commonly use have anticholinergic side effects, and I'll mention some of these later when we get to the Beers criteria. Appropriate dosing is very important also. We should start with low doses, but after monitoring the patient for side effects, we should go up on the dose in order to achieve therapeutic effects while constantly monitoring for side effects. We should aim for less frequent dosing, especially for older adults, for which frequent dosing is often hard to remember. What else can we do? We can review frequently, ask the patient to bring their medications in, or at least an accurate medication list. This may be time consuming. You may ask your nurse to help with some of this review, to look through the list and write things down. Counting the pills can be helpful to see if the patient's taking the right number. This is potentially time consuming but very rewarding. Next thing, avoid iatrogenic cascade and avoid inappropriate drugs. These last two things each are so important that they have their own slide. So let's go to iatrogenic cascade. Any symptom in an elderly patient should be considered a drug side effect until proven otherwise. This sounds like an extreme statement, but it's actually very helpful and useful thing to keep in mind, and often turns out to be true. So again, instead of adding more medications when we see a patient, an elderly patient with new symptoms, we should first stop and think, is there a medication that could be causing these symptoms? If that's the case, then it's better to stop that medication rather than to just keep adding more medications and cause an iatrogenic cascade. Here's an example of an iatrogenic cascade. I'll just let you read that. So in this case, the doctor is choosing to use Valium to treat the side effect of the other medications. In this case, the side effect is cost, but we often see other side effects, as you can imagine. Beers criteria. Well, Beers criteria are a list of potentially inappropriate medications developed by a group of experts by consensus, and there's a long list and a nice article that explains it all, and the link is there, and you can look at this and read the full article for yourself. Practically speaking, it's difficult to remember more than 100 different medications that are listed in this, but if we think in practical terms about the ones that are listed at the bottom of the page, then it can be very helpful. So benzodiazepines are the first one to consider because they commonly are used for sleep or anxiety, and the major side effect is altered mental status, drowsiness, which in turn leads to falls and injuries. Long-acting benzos are particularly problematic because as one gets older, the half-life gets longer, and so even if it's used purely as a sleep aid, the half-life can be so long that the patient is still drowsy when they wake up in the morning. So that's something that definitely should be avoided. And there are alternatives, of course. One can use SSRIs for anxiety, one can use other medications for sleep, such as sleep or non-pharmacological strategies for sleep, such as sleep hygiene. When we come to antidepressants, some of the antidepressants, especially these older ones like amitriptyline and doxepin, have a lot of anticholinergic side effects, which, as we mentioned before, we should try to avoid. In terms of antidepressants, SSRIs are probably the medications we should be choosing most of the time. But fluoxetine is the exception because it's more stimulating in older patients, and so we should probably avoid that one. But the other SSRIs are fine. Sedating antihistamines, such as Benadryl, Atarax, these are commonly used for itching or sleep, or for allergy symptoms. And they're good drugs, but in elderly patients, the anticholinergic side effects will bite you. So we should try to avoid these drugs in those patients. NSAIDs are commonly used in the elderly because arthritis is a common disease in the elderly, and NSAIDs seem to be the drug of choice. However, they have major side effects, including GI bleeding, which is at a much higher rate in older adults than in younger people. Renal failure, again, much higher incidence in older people, and congestive heart failure or exacerbation of congestive heart failure due to fluid retention. And there are alternatives to NSAIDs for pain, such as physical therapy, other non-pharmacological therapies, topical therapies, and other medications that are available, such as acetaminophen, which can be used if used at adequate doses, is very effective for chronic pain, and SSRIs can help in chronic pain, and Neurontin and other drugs like that can help in chronic pain. So we have options to consider. Finally, by way of conclusion, patient safety and medical errors are a major problem. Polypharmacy is the example that we were using for decision-making errors. It's a common problem, especially in the elderly, and can be avoided by careful prescribing and frequent review. Patient mistakes is what we talked about at the beginning, and as we said, these are due to systemic problems mostly. So we shouldn't be blaming the patient. We should be thinking about what we can do to help the patient navigate through the system, and what we can do to improve the system for the future. That completes the talk. Thank you very much. And there's a little thought to conclude. All the best. If you have questions about anything, please email me. My email is in the packet. Thank you very much.